Good morning, afternoon, and evening, everybody, and welcome to this webinar on monitoring in FLS. My name is Eric Brudet-Champagne. I'm the Capture the Fracture Coordinator at the International Osteoporosis Foundation, and I'll be the moderator for today's session. Before introducing our speakers, I'd like to inform you all that all participants are automatically muted for the duration of the webinar. I'd also like to encourage you to ask questions during the session by typing them in the question box of the control panel on Zoom. Today's webinar will feature two presentations, followed by a question and answer session, and I'll voice the questions to our speakers during the question and answer session planned at the end. With this introduction completed, I'll now introduce today's first expert speaker, Professor Willem Lems. Professor Lems has been a rheumatologist since 1993 and professor of rheumatology since 2008 in metabolic changes in patients with rheumatic diseases at the Amsterdam UMC in the Netherlands. He's current educational officer of the Amsterdam Rheumatology and Immunology Center. Professor Lems has published extensively with around 460 PubMed publications to date and is a member of the Capture the Fracture Steering Committee. It is now my pleasure to leave the floor to today's first speaker, Professor Willem Lems.
Okay, thank you, Eric. Ladies and gentlemen, it's a great pleasure and honor to speak here on this IOF webinar on the topic adherence to therapy, one of the biggest challenges in the field of osteoporosis. I do realize it's not one of the most sexiest topic, but it is a very important point, and I want to discuss it with you all. Next slide, please. So what are we going to discuss today? What I'm going to discuss today? That the adherence in osteoporosis patients with oral bisphosphonates is suboptimal, but also that the adherence with parenteral drugs is suboptimal. We are going to discuss what are the reasons for that, what are the underlying mechanisms for the non-adherence. We're going to discuss about the effects of BMD measurements and bone turnover markers. Will that help on the adherence? And in the end, I go into some experiments with positive effects on adherence. So I start with a study from the Netherlands with several oral anti-osteoporotic drugs. And you can see that after 3 months, roughly 30% of the patients have stopped their osteoporotic products. And after a year, more than 50% have stopped, and that's a serious percentage of patients. Thus, there is a serious issue. Next slide. This is a slide from Belgium, and we focus on the left part of the slide. And you can see in the black bars the patients treated with weekly oral bisphosphonates, and the gray bar the daily. And you can see that roughly 40% of the patients with daily bisphosphonates are still adherent after a year, and with weekly it's around 50%, a little bit better, but still suboptimal. There's not only in the Netherlands, but also in Belgium. And the next slide. Here you see a comparison between drugs that are branded risedronate and branded alendronate in red and blue lines, and the green line is the group of patients with generic alendronate, and you can see again that the adherence is lower, which might be a result of lack of support by pharmaceutical companies, but it can also have something to do with more side effects with the generic or other reasons. Next slide. And finally, in the field of rheumatology, we see the compliance and persistence of oral bisphosphonates here over a longer period of time, not only of 1 year, but over 4 to 5 years. And you can see that after 48 months in the patients treated with weekly bisphosphonates, the adherence is only around 20%. So okay, I can go on and on with showing you several studies, but maybe it's better to look at the review. Next slide. And this is a review from 2019 from the BMG. And it's a review based on 89 observational studies from 15 different countries. And the calculation of persistence and adherence and the definitions were heterogeneous, so no meta-analysis was possible. But the data give important insight in the issue of adherence. In the first 6 months, the percentages of persistence varied from 35% to 71%. During 12 months, it varies from only 17% to 75%. And after 24 months, it varies from 30 to 70%. So much lower when over longer time. And after 36 to 60 months, there are no data presented. So clearly, low adherence to therapy is a big issue in the field of osteoporosis. Next slide. Does it matter? Yes. Here you see a study of only 2 years observation in Germany. And you can see that the patients who are compliant to their osteoporotic medication have a lower fracture risk than the patients who are non-compliant already after 2 years. And it can be the result of taking more pills than in the non-compliant group. There can also be other differences. Maybe these group of patients who are compliant are more healthy, but it suggests the idea that compliance to therapy is important and might be result in a difference in fracture rate. Next slide. And in addition to that, here a study from South Korea observing hip fracture patients over a longer period of time, over 5 years. And in the upper line, you see the patients who are compliant to therapy, taking more than 80% of their pills. And in the two lower lines, the group of patients who are taking no pills at all, or less than 80% again. And again, you see a difference here in survival. Again, it might be related to the intake of anti-osteoporotic drugs. There might also be a difference in health status in the compliance versus the non-compliant patients. Next slide. Is it an issue only in the field of osteoporosis? No, it's also in other fields. For instance, in the cardiovascular field, if you look at the adherence to clopidogrel and other antithrombotic drugs, adherence can be low. And the idea is that adherence is particularly low in patients in drugs that are used for prevention. I'm a rheumatologist. Patients in the field of rheumatology who forget or didn't take their pills for whatever reasons generally get more pain from their arthritis. But that's not the case in osteoporosis. If you don't take your anti-osteoporotic pills, nothing happens directly. Maybe you have a higher risk of fractures later. Next slide. So what about parenteral drugs? Many individuals think that the adherence is better in parenteral drugs, but let's see what's the reality. Next slide. Here you see a study from US observing of the denosumab in the blue line subcutaneously, ibendronate in IV red, green teriparatide subcutaneously, and IV zoledronate in the pink line. And roughly after 2 years of observation, 50% have stopped their parenteral drugs. So also in the field of parenteral drugs, adherence is suboptimal. This is only one study, but let's look at the review. And you can see in this systemic review in panel A and B, the persistence and adherence for teriparatide is roughly around only 50% after already 12 months. In C and D, you see the persistence and adherence for ibendronate, that's roughly around only 40%. E is zoledronic acid, after 2 injections, only 50% adherence. And F is denosumab, only after 2 injections, 80% is adherence. So also parenteral drugs have a low adherence. Next slide. And then the crucial question is, what are the reasons, what are the mechanisms for non-adherence? Next slide. And there are numerous. There's a large overview from Hilliksman, and there are several reasons. The first one is patient-related. There's a misconception about osteoporosis. Many patients can tell you that their fracture is probably traumatic and has nothing to do with low bone quality. There's often a lack of insight in the high risk for future fractures. Additionally, there's a fear for side effects, probably that's coming more and more over the years. And many patients prefer a healthy lifestyle above the intake of drugs. Remarkably, there is also a misconception by many physicians. Many physicians have the idea that osteoporosis is just age-related and not related to a higher fracture rate. And in addition to that, many physicians are busy with all other items outside the field of osteoporosis. Therapy has also an effect on non-adherence. There may be side effects. There's often fear of side effects. And the intake regimen is also important. I already showed you that the intake of weekly bisphosphonates is better than that of daily bisphosphonates. There's also condition, background related. Patients who have polypharmacy, already upper GI diseases or upper GI complaints, the adherence to therapy for oral bisphosphonates is lower. And there is also the health system related issues, costs, and also the phenomena that many patients from the FLS are the treatment is initiated by the medical specialist, but in the second phase, the GP is in charge, and that's not always functioning optimal. So several reasons for non-adherence. And what can we do about it? Does it help to do B&D measurements? Does it help to measure bone turnover markers? I will go into detail about that. On the left side, you can see if you treat a patient, for instance, with risedronate, and you want to measure a treatment effect, you need a larger increase in B&D than the least significant change. And usually you have to wait 2 years for that. And that's a long period. One of the attractive issues of bone turnover markers is that the decrease in bone turnover markers already can be found after 3 months, so much earlier. Next slide. And these slides you can find of the IOF websites. It's a Triodos study from Richard Eastle and others. You can see that the effect on bisphosphonates on serum CTX is very large. If you measure it after 3 months in the majority of patients with ibandronate, alendronate, and risedronate, the bone markers are below the least significant change, below the thresholds. That's on the left side for CTX, a marker of bone resorption. And if you look at the right side, you can see more or less the same for P1 and P, a marker of bone formation. Usually, in my opinion, the changes in serum CTX occur after 3 months. For P1 and P, you need somewhat more months, maybe 4 or 5 months. Next slide. So this leads to a very important and attractive algorithm that I'm used to, that we are using in our academic hospital in Amsterdam. Patients starting with osteoporotic drugs, we measure at baseline P1 and P and CTX. After, let's say, 3-4 months, we measure the bone markers. If there is a decrease of more than 30%, that's the least significant change. That's a reason to continue the treatment. And for many patients, that reinforces them to go on with the therapy because they know that it has an effect. On the other hand, in some patients, there's no decrease in bone markers or only a small decrease. And then we discuss about the intake of the drugs. Sometimes the patients don't have drug to bisphosphonates at all. Sometimes they take it wrongly. Remarkably, some patients still taking it with their feed or with milk. But there might also be other causes, for instance, a secondary osteoporosis, sometimes a period of bed rest for lumbar spine or something, hernia. And there can also be a lack of efficacy. Remember, only 1 to 3% of the oral bisphosphonates are absorbed in the intestine. And in that case, we start with a second-line drug, usually zoledronic acid or denosumab, or alendronate in drink form. Next slide. So I think the IOF is a very attractive educational site, which shows you several slides which you can use for lectures or presentations for your patients or general practitioners or others and it has several topics. But next slide, what is missing is a slide set on monitoring, and in my opinion, it's a very important point. How effective is monitoring? This is again a study from Richard Eastle. You can see in the lower line the monitoring in the patients without any monitoring, and you see half of the patients have stopped their drugs after a year or so. And if you use bone markers, that might lead to reinforcement, and it is much better. But quite remarkably, if you don't measure your bone markers and there are regular visits or contacts with the nurse, that's the same effect as the measuring of the bone markers. So monitoring and follow-up is crucial. Next slide. It has also been looked more in detail by the late Pierre Delmas and others. You can see here a little bit complicated slide. The upper line is the persistence of the drug in patients in which there's indeed a decrease of more than 30% in their bone markers. The lowest line is in the patients in which there is an increase in bone markers, and then is the persistence very low. Probably that's a group which has another disease leading to increased bone formation, bone resorption and bone formation. The lines in between are the patients without any monitoring and the patients with monitoring but with no changes in the bone markers, all suggesting that bone marker measurement might have an effect, but the final proof that it's useful does not exist. Next slide. Finally, some experiments with positive effects on adherence. Next slide. This is a study from the Netherlands looking at teriparatide. The lowest line is the adherence to teriparatide, and the upper line is after the start of a basic support program. That means contact by a nurse who gives some education about osteoporosis and some motivational interviews about the importance of continuing the teriparatide. And you can see that the adherence increases from, at the end, 70% to 80%. That's an increase of more than 10%. Next slide. This is a relatively recent study from Austria in patients with denosumab. After 15 dosages of denosumab, so after 7.5 years, the adherence is more than 70%, so relatively high, a good result. But next slide, you can see that there is an increase in bone mineral density and a decrease in the bone markers, but also you can see that there was a yearly bone mineral density measurement, and twice a year the bone markers were measured, and that's a costly situation. So yes, you can improve the adherence to denosumab, but measuring and the bone mineral density and the bone markers is probably a little bit too much. Next slide. Then what happens after a fracture? We did a study in the Netherlands in four centers in patients at an FLS. Patients with 50 years and older with a fracture were invited to the FLS. And in the end, in 337 patients, osteoporosis was diagnosed and treatment was initiated. We followed these patients for a year, and after 12 months, the follow-up was that 88% were still persistent after the fracture with anti-osteoporosis therapy, and the same was found in France. 80% were still under treatment after a year, and the reasons for that is probably that the patients had a recent fracture that motivates them to take their anti-osteoporotic pills, and there is a selection that not all patients who are invited are coming to our outpatient clinic. Nevertheless, this suggests that the fracture liaison might be a very attractive model for improvement of adherence. Next slide. So I have 3 summary slides. The first one is adherence to drug treatment is a serious topic in osteoporotic patients. The adherence of only 50% after a year is often observed. For parenteral drugs, it's better, but still only 50% are adherent to treatment after 2 years. And it's very clear that the low adherence of around 50% after 1 or 2 years has a negative effect on fracture reduction, because according to guidelines, intentional treatment is 3 to 5 years. And there are many reasons for these low adherence: patient-related, physician-related, drug-related, system-related. Next slide. Bone turnover markers might be helpful in improving the adherence. by finding a decrease in bone turnover above the threshold, it might reinforce patients after already 3 months to continue their therapy. And on the other hand, it may help to early detect ineffectiveness due to lack of adherence or due to other reasons. It's important to realize that monitoring by regular contacts with the nurse might also be helpful. And finally, slide 3. What are the promising experiments? Both educational and motivational programs may be helpful, and intensive follow-up with and bone markers and DEXA have been shown favorable results. After 1 year of follow-up at the FLS, 90% are adherent to drug treatment, probably related to the fear of another fracture and because of selection. So the big question is, and Professor Javaid will go into that, can in the real world the fracture liaison surface be a helpful instrument in improving adherence? Thank you for your attention. And I'm open for questions, of course.
Willem, while we wait for questions, that was fantastic. Thank you so much. One question I had is, what are you doing locally in the Netherlands to improve adherence? You talked about the teriparatide study, but you also brought up the post-FLS rates, which are very impressive. You mentioned some limitations. What's your take and plans for the Netherlands?
Let's say there are several ways to improve the adherence. The worst thing is doing nothing. Better is measuring bone markers or regular contacts with your nurse. And the best option is probably is the fracture liaison surface, which is the probably has the most the best chances to be very successful in the end.
I'll just pause for Eric. Should we go on to the next talk, Eric, or are there other questions?
Yeah, I think we'll keep the other questions for the question and answer period at the end of the webinar. So that'll bring us to your talk, Professor Javaid. So I'm going to briefly provide the introduction for those for the audience here.
You can keep it short, Eric, don't worry.
Perfect. So Associate Professor Kassim Javaid is Associate Professor in Metabolic Bone Disease and Honorary Consultant Rheumatologist at the Nuffield Center for Orthopedics, Rheumatology, and Musculoskeletal Sciences at the University of Oxford, with a research interest in secondary fracture prevention, vitamin D, and rare bone disorders. Professor Javaid has led a fracture liaison service since 2008 and FLS networks regionally, nationally through the FLS-DB National Audit, and internationally through the Capture the Fracture program. And Professor Javaid is co-chair of the Capture the Fracture Steering Committee. So with this said, I leave the floor to you, Professor Javaid, for the second presentation.
Should I share my screen?
Yeah, please go ahead.
Thank you. Okay, well, thank you so much. And my job's been so much easier with that amazing introduction from Willem. So there are my disclosures. So Willem's already really nicely summarized the importance of monitoring, the current status of monitoring, and some very impressive results in the FLS setting. And he's pulled in this article on an overview of adherence to antiosteoporous medication. I put some references also there for how that can be applied to the FLS setting. The topic I was given, challenges of monitoring from the FLS perspective, and I'll divide these into 5 key strands. So many of you know that an FLS is a fracture liaison service, small group of doctors, nurses, administrators, and other healthcare professionals who follow templated pathways, high volume, low complexity patients to get them on treatment. And monitoring is a very important part of the fracture liaison service. It's an evolved indicator, and it's really an opportunity to check the patient started treatment, reinforce motivation, and check, importantly, if they need to swap treatment because of problems following the administration, the frequency of dosing, issues around tolerability, new cautions, changes in comorbidities, and changes in fracture risk. So monitoring is important across osteoporosis, but there's a special focus for FLSs. And we've sort of encapsulated the criteria for a good FLS in that it identifies 80% of the eligible population, recommends treatment for at least 50%, but critically makes sure 80% start and stay on treatment. And we say this because when you look at data, this is data from the national audit that we run in England and Wales. So in 2021, you can see the rates of identification, treatment, and monitoring. And if you apply those rates to then the number of people on treatment at 12 months, just over 3,000. And you can see with applying the 80-50-80 rule, you get a almost 8-fold increase in the number of patients. And the biggest uplift is in monitoring. So monitoring is not, as Willem said, the most attractive or intellectually stimulating part of a pathway, but it is hard to get right. I think it's something that good FLSs should be known for. So what are the challenges for getting monitoring right in the FLS setting? Well, the first one is the FLS is a very simple concept. Find people who've had a fracture, see if they're at risk of another fracture, and then intervene. However, this is applied to a very complicated healthcare pathway for the fracture patient, from emergency room, orthopedics, geriatrics, internal medicine, radiology, and biochemistry in the secondary care setting, and then longer-term therapy in the primary care setting. And in project management, this is a very volatile environment. You can get huge changes in patient numbers, staffing, hospital systems, and primary care activity. These changes are unpredictable, and they're very complex because often we have different stakeholders involved in the process. And unfortunately, we never know all the information. We never quite know what's happening in primary care or in different departments that are not part of the FLS. So the first challenge is the environment. This also has to bring home that there is in many countries, a gap between the hospital setting and the community setting. And this chasm or gap in patient care is a really important challenge to effective monitoring. The second challenge is awareness. How do you know if you're doing monitoring well? And this is something that's really something we have tools for, but aren't being implemented very well. So we can measure awareness at the organizational and at the patient level. And the optimal tool for this is the best practice framework from the IOF and Capture the Fracture. And this is based on benchmarking across 13 criteria with standards for each. And I'll show you the standards now for a long-term management. You can get bronze if you do one monitoring visit within 12 months, and then gold if you're doing short and long-term monitoring. And a real transformative approach to this is that this questionnaire is now online in multiple languages. So anyone can freely log on to the Capture the Fracture website and get mapped. Standard 12 is a long-term management, and this gives you some idea of what you're trying to achieve during your monitoring visit in terms of what does the reevaluation include, which patients go through it, what time intervals, how you calculate the time interval, and then the method and the person who's developing the monitoring. And a much underused purpose of the framework is to give your FLS an organizational scorecard. So here you can see an example, and many others exist, where you've got the different standards on the left, and for the columns you've got the major fracture types: hips, other inpatients, outpatient setting, and then spine fractures. And you can see very often a long-term management is the one that is missing in the FLS strategy. So if you don't even have monitoring as part of your pathway, you can stop there and introduce it. But what happens if you do have a part in your pathway? How can you see if it's made a difference? And here we can use patient-level key performance indicators, which are used to really understand the impact of the FLS on medication initiation and adherence at the patient level. And you can do exactly the same with the organizational system. You can set up a scorecard, and then you can add in what your current performance is across the different types of fracture for initiation by 16 weeks and then continuation at 52 weeks. So we talked about methods of awareness, and we talked about the complexity of the environment. Another big challenge is capability. Now, capability in the FLS setting usually focuses on osteoporosis medication, FRAX tools, interpretation of DEXA, choice of medication, laboratory testing, and secondary causes. What we really need to do is build the capability in skills in monitoring. Willem mentioned motivational interviewing and other interventions. This has to be core for building the capability of the FLS to deliver. But there is another aspect to this that also needs to be included, and that is around quality improvement or healthcare improvement. We need a system where we can easily and efficiently improve monitoring for our services. So rather than a very simple, let's do this, let's try this, there is a pathway of service improvement that can deliver this. And this uses data from both the Capture the Fracture Best Practice Framework as well as data from the key performance indicators. And a real important capability is our ability to work with our patients and carers to co-produce the improvements in monitoring. It's very hard for anyone to improve monitoring unless in that discussion are the people who will be monitored. And there are now a number of different schemes where you can plot the improvement in care from identifying the team, checking the pathway, and then moving on to interventions. So that's capability, and that can be addressed through training. The next hurdle is capacity. We have an aging demographic, we have more fracture patients, and yet we have fewer staff and under-supported systems, maybe short-term contracts or uncertainty around delivery. So on the one hand, we want to see more patients, but it may actually be a discussion where we see fewer patients and monitor more of them more completely. And that is a very hard discussion for FLSs to have, that actually we're not going to see certain fracture types because we need to make sure the patients we have seen are adequately supported and monitored. And an evolution of that approach is actually see fewer patients so you can improve. Undergoing formal service improvement takes time and can't be something that's just layered on to the current activity of the FLS. So if you have FLS capacity that's fixed, to do service improvement will mean that you will be seeing fewer patients. And the main issue around here is that we have very few papers that can demonstrate the impact of quality improvement in terms of benefit for patients. And the main reason for that is that we haven't optimized how to do quality improvement in the FLS setting. What is the best model, workflow, program an FLS should undertake to deliver healthcare improvement? And I really do think it's only by optimizing the current pathways of healthcare improvement we can show we will be able to answer this question. And actually by seeing fewer patients, by doing service improvement, you are making major reductions in patient fracture risk and improving patient benefit. There is some data on this. This is data from England and Wales Fracture Liaison Service database. You can see here the KPIs. It doesn't matter what they mean, but each KPI is part of the pathway mapping to the international pathway. And you can see the bars for 2018, 2019, and 21. And the orange means 50 to 79% achievement, and green more than 80%. And generally we see, as you go from 2018 to 2021, there are more FLS units offering green or orange level standards. And this is actually very encouraging. But the question is, could this be steeper? And how much of this is due to healthcare improvement? And we really need to start modeling how many extra fractures we're avoiding by doing these sort of activities so we can justify the effort in undertaking this work. But there are other things we can do. If our capacity is fixed, we can become leaner. So we can see more patients with fewer staff. We can implement digital solutions. This may be the patient pathway, because we know lots of FLS time is spent doing admin, or using AI technologies to identify patients. We become leaner in our delivery of healthcare improvement for monitoring. So we can maybe use evidence-based DEXA intervals, as Willem suggested, We can use remote assessment rather than clinical assessment for monitoring. We can use primary care prescription data and have very clear next steps in the pathway. So when we do monitor, we can do many more monitoring visits with greater impact with the same resource. And then we can make our service improvement leaner. We can make our data evaluation semi-automatic. So from our record systems, we can automatically develop those important benchmarking and run charts that show how we're performing. And then we can digitalize and regionalize our availability of resources and workbooks. So finally, just to close out, this is an example from the UK with the national level databases. And here you can see, anyone can access this. You can see at the regional level, the performance for monitoring and also the other KPIs. And here you can see for all the KPIs, I've ordered them in terms of KPI 11, which is 1 year drug adherence. And the best center was Walsall Healthcare with 75.9% adherence at 1 year with 720 patients submitted. And you can see the values for others. But is that enough just to provide the data? Well, if you're look at the data, well, probably not. So on this graph, we have the number of patients who are reviewed within 4 months of their fracture as the national average. And you can see it's quite disappointing. We're from 10 to 30%. And now I'm going to show the data for people on treatment at 1 year as the national average. You see it's not much better. Now this, of course, is only reflecting the people whose data was recorded. So there is a lot of missing data here that pushes down the average. But this is way off what we want to achieve. Willem has been talking about 80% adherence at 1 year. And I've shown you previously, many FLSs are not hitting this. So I think the next challenge is to say that it's just not enough to provide the data. We need to use local delivery of improvement. If we really want to improve monitoring for the FLSs, we need to set up systems that deliver this improvement locally. And the best way to do this, and this is the final challenge, is through regional networks. Having large national projects doesn't really produce the engagement and momentum that you get from a regional project, maybe from the south of the country, the north of a country, where you have a number of mentors who support FLSs and you develop ownership, clusters of practice. You can undertake regional advocacy and guidelines if there are particular areas, and you can really push in behavior change. Mentors can help FLSs get started, mapped more effective. There can be coaching calls. By having these regional networks, FLSs learn so much from each other, and there are now digital platforms to develop this. So in summary, there are challenges for monitoring in the FLS. I hope I've been able to share with you the challenges at the environmental level, the awareness level, capability and the skills required for this, as well as capacity to do this when we're all so busy. And then finally, the critical role for local FLS delivery really being linked to regional networks. So I'll pause there, Willem, and I'm happy to take any questions and then move into the general discussion.
Yes, I'm starting with a question for you, Kassim. After a brilliant presentation, thank you very much for that. The first question could be, what are your thoughts about the experience of monitoring in UK? Are you happy with that? And the second question is, what can others learn from that?
Really good question. So, I mean, Alison McClellan and Stephen Gallagher started FLS off in the late 90s, and it didn't include monitoring. It was truly the one-stop shop where you came in and left monitoring to primary care. So we've evolved from that model to one where we're pushing more FLSs to do the monitoring calls. But monitoring is literally checking in. What we really need is better support for patients after they've left the FLS and before each of the monitoring calls. And in the UK, there are programs now where we can use GP data, primary care data, to use the pharmacists to actively find patients who stop treatment. I think our biggest change is we've moved from passive detection, from patients telling us, oh, I've stopped, to active detection of non-adherence. And I think that's been, the patients have been very surprised, And in a way, they're kind of like, oh, I didn't realize it was that important. You're asking me, no one else asked me, so I stopped my medication. But it's that active shift. And what we now need to do is use digital technologies where we can make that easier to do. And we can link the patients to local support groups like the Royal Osteoporosis Society in the UK or other groups to really support them to become more engaged with their treatment. Because at the end of the day, the FLS can't replace primary care, but we can work with them to provide a better support structure for the patients. And I think that's where we are in the UK. We've got the challenge, we can measure how well we're doing. Now we need to invest in primary care initiatives to support the patients after they've left the FLS visits.
Okay, thank you for that. Are there other questions?
Yeah, so I'll come in with a question here. So the question is, can you use bone turnover markers after a fracture?
Yeah, that's probably a question for me. The question is correct. After a fracture, you have an increase in bone formation markers and bone resorption markers. What we are doing in Amsterdam, usually, I must say, we see the patients at the outpatient clinic 3-4 months after the initial fracture, and that effect has been waned off. So if you don't use the bone markers too early after the fracture, I think we can use them. And obviously, what we are doing, we measure at baseline at the outpatient clinic, and 3 months later, if there is no decrease at all, the patient doesn't take pills or something else. And if there is a decrease of 30 or 40, 50%, which we see quite often, then they're using their pills, and it really reduces their bone resorption.
Great, thank you, Professor Lems. The next question here is that you mentioned 5 challenges to achieving good monitoring. Where should FLSs start? And this is a question more for Professor Javaid.
Yeah, that's a really good question. I mean, I've given you the whole jigsaw of the complexity and the challenges. But actually, the first step is really simple. It's just to set up your team, to get your FLS staff, get 2 or 3 patients, to set up a team who can then look at how the monitoring is going in your FLS, use the data, and then use healthcare improvement techniques to go forward. I think it's just recognizing that it's an issue and then investing time and effort to deal with it. It's much better to do it that way than to do very rapid, almost instinctive changes to an FLS pathway. It's much better to do it together with everyone in the room, make sure all the actions are deliberate, purposeful, and you're going to measure the outcome. Because what you really want is sustainable change. So it is hard, it's much easier with a team, and that's where you should start.
Okay, great, thank you. So here, this is a question again for Professor Lems, saying that they're surprised about the adherence for osteoporosis is so low. And can you tell us more about the reasons for that?
Yeah, that's a very good question. It starts with the patients. Many patients have the impression that their fracture is not related to osteoporosis, but to a big trauma. That's the first idea. Other idea is that there's no increased risk for future fractures, and there is certainly a fear of side effects. Quite remarkably, there are also many physicians who don't think the risk of osteoporotic fracture is so high, and there are other reasons. The cost of the drugs, the rhythm of taking the drugs once every day or once every week before your breakfast, and so on. So there are many reasons for not starting or the drugs, or being not adherent to drugs.
Okay, and just to follow up on that, so in your practice in Amsterdam, how do you work to optimize adherence? Yeah,
let's say we believe in the bone turnover markers, and let's say the combination of the bone markers, and I've shown the data that in many patients there's a big decrease already after 3 months. And if you have an enthusiastic physician about that results, that reinforces the patient that they at least know that taking their drugs is working, that their bone resorption is going down, and we believe in that. But I do realize there are also data that if you just have a trained nurse with education and motivational interviews, that works probably as good. It's far clear for my lecture, I suppose, if you just diagnose osteoporosis and write down a receipt and take your pills for 5 years, you must not be surprised if your patient does not take their pills. So you must do something, either follow up by a nurse or in the end a GP or measuring bone markers. But you need to do something, and we don't know what's the best of that, but you need to do something to optimize the monitoring. That's the topic.
Yeah. And when talking about using DEXA for adherence monitoring, how long should we wait?
Let's say you should wait for 2 to 3 years, because you need to find the results that the increase in bone mineral density after taking the osteoporotic drug should be bigger than the least significant change. And in the end, you must wait 2 or 3 years. And it's quite a long period. So let's say a patient after a year has no idea whether the pills he or she, usually she is taking, has any effect. And that's the big advantage of the bone markers. You can already see after 3 months whether it's working. If it's not working, you give another drug. And with BMD, you have to wait 2 years or more.
So thank you. So to the audience, if you have any other questions, please share them. To continue the discussion, what would be the role for GPs in monitoring?
I think that what we learned from this session, that if you don't do anything in the field of monitoring, you must not be surprised that your patient is not taking the pills. Usually, the diagnosis is initiated and the treatment is initiated at the FLS, but most patients go after that to the GP. So it's very important to collaborate with the GPs. They should continue the medication and trying to be that the patients are adherent to their drugs. So GPs are becoming more and more important, and collaboration is crucial, in my opinion. I don't know what Kassim's idea is about that.
No, I completely agree, and I think they should be part of your team. I mean, I think we should work together. They're very busy, but there are often small changes we can make to make it easier for the GPs, even if it's just having a helpline they can call if they've got questions, or producing frequently answered questions. We get a lot of questions around denosumab, or when to give zoledronate, or renal function, or vitamin D. And if we can make it simpler for the GP, who's often looking after many more conditions than osteoporosis, it's logical they should come to the people who only do osteoporosis or rheumatology first, or endocrinology. So I think bringing them into the team, you only need 1 or 2, and they'll represent hopefully most of the others.
Great. Okay, well, thank you very much for this very insightful discussion. I think we'll wrap up the webinar here. So I'm just going to share my screen for some closing remarks. So on behalf of the International Osteoporosis Foundation, I would like to thank everybody for their participation in this webinar, and I hope that you enjoyed the session. You'll be prompted to complete a brief survey immediately after the webinar, and we'd appreciate your input and comments as we continuously try to deliver webinars that meet your needs. If you have any questions or comments, please don't hesitate to contact us by email at capturethefracture@osteoporosis.foundation. The email address is linked in the chat. With that, I would like to thank Professors Lem and Javaid one more time for their outstanding presentations, as well as for the insightful discussion after the session. And I'd like to wish everybody a pleasant morning, afternoon, and evening ahead. Until next time, thank you, everybody.
Bye.
Bye.